Thank you so much for having me, Marina. It turns out that we have a lot of things in common. My children are now 6 and 7. I'm not sure. Do I have video, or do I need to get it to go up?
You have your video showing, and we'll take care of the slides for you.
All right, wonderful. Thank you. So we definitely have that in common. And if you would go to the next slide, that would be great. So I am a headache neurologist. You heard my background in terms of doing neurology residency and headache fellowship and obstetric neurology training. And I'm head of neurology at Novant Health here in Charlotte. And I'm a former breastfeeding mama for my 2 boys, who are now 6 and 7. And it was for a collective 32 months that I was able to breastfeed them, which I'm very grateful for. I am on speaker or advisory boards for multiple different companies. And so I do think it's very important to have that disclosure in there. And everything I'll be saying today is meant for educational purposes, but not for direct advice. And so please defer to your regular provider for medical decision making. And everything I'll be talking about today, just assume it's not FDA approved, because nothing is FDA approved in lactation. That doesn't mean that it can't necessarily be used, but it does mean that there's worth a discussion about each medication when you talk to your provider about it. Next slide. So this talk is really focusing mostly on the postpartum period, although it is worth mentioning a little bit about just headache in pregnancy as well. So in the general population of non-pregnant, non-postpartum patients, primary headache from migraine disease accounts for about 95% of headaches. Secondary headaches, meaning headaches due to tumors, strokes, bleeds, aneurysms, cerebral venous thrombosis, et cetera, accounts for 1 to 3% of patients. So it's a very slim number of patients who have headache that it is due to one of these ominous causes. And then other primary headache syndromes like the trigeminal autonomic cephalgias also account for 3 to 4%. Now, what happens in the obstetric population? The stakes are higher. We have to take it quite seriously if somebody does have increased headaches. 50% of patients who have migraine disease at baseline have some improvement in their headaches while they are pregnant. About 25% of patients, their migraine disease stays about the same, and 25% of patients, their symptoms worsen. And particularly in those patients whose symptoms worsen, we have to have a level of concern as to why that's happening. And it could still be primary migraine disease, like how Marina described. I also had a pretty significant uptick in migraine attacks during pregnancy for both of my pregnancies. However, we can't just take that for granted. If I have a patient who's coming in with an increase in their frequency of attacks during pregnancy, I'm pushing for imaging for them. And we'll talk more about that shortly. If you can go to the next slide. So if somebody is having that uptick in frequency of headaches, doesn't even have to necessarily be migraine attacks, but just headaches, any kind in pregnancy, I have a level of suspicion that there might be something going on. And so MRI is the imaging modality of choice in pregnancy and in lactation. If somebody is pregnant, we do avoid gadolinium. It is formerly category C, but there is some potential risk in pregnancy. However, in breastfeeding, it is okay to use gadolinium. Gadolinium is the contrast that we use. So when you hear people talk about MRI with and without contrast. So it is not contraindicated in breastfeeding. It is a contrast-based media, and it has a half-life that's pretty darn short of only 2 hours and nearly completely cleared from the bloodstream in somebody who has normal kidneys within 24 hours. And it's excreted in the breast milk in a tiny quantity of 1 in a million. So the maternal dose is really not really reaching the milk. And interestingly, if a baby themselves needs gadolinium because they need to be imaged, it's a much higher dose that they're receiving when they actually receive a bolus of gadolinium for their own imaging. So take home message, don't pump and dump. If you have some radiology tech who's feeling froggy and wants to tell you to pump and dump, you can either confront them and tell them no, or you can just kind of roll your eyes and go, sure, and then go home and not necessarily actually pump and dump, feel free to continue to breastfeed with that. So what is migraine? I know I'm talking to a very educated audience, but so, it is a throbbing headache that is moderate to severe in nature that has associated symptoms of either nausea and vomiting, not with or without vomiting. Vomiting is not necessary as part of it, or light and sound sensitivity, or some combination of both. And about 20% of patients have aura with their migraine. And so whether that's visual aura, sensory aura, word finding problems, which is aphasia, all of that can go with it as well. So it's not just a headache. It is definitely more debilitating than a tension headache because of the other symptoms that go along with it. And 39 million Americans have migraine, and it's 3/4 women to men. And so who are we? We're women who are, of childbearing age. We're women who are getting pregnant, breastfeeding. So, to have treatment options during this really vast period of our life is so profoundly important. Next slide. All right. And so women can get the improvement in their migraines during pregnancy, but not always. And then in breastfeeding, there might be a protective effect. However, and that's also during the lactational amenorrhea is what they're thinking is the reason for it. My own personal experience, though, was that I had way more tension headaches during the postpartum period, and that was due to probably the sleep deprivation. And if somebody is quite sensitive to sleep deprivation as a trigger for their migraine, they can have increased migraine attacks during the postpartum lactational period of time for that reason. I'm, super proud of my breastfeeding history, but I do think that, truly fed is best. And so I think that taking into account what is best for you and best for your infant is so important. And by best, it means that you need to kind of weigh all of your options and think about, your own quality of life when it comes to this. So if breastfeeding or pumping, EPing are options, I think that that's great. And if it just is not feasibly an option due to neurologic disease and because of the lack of sleep, completely understandable. You have my emotional permission that you need to choose what's best for you. Next slide, please. All right. And so in patients who are in the postpartum period, there can be recurrence within about almost half of patients can have reoccurrence within that first month. So, hey, there's still half that aren't having that reoccurrence that soon, but it certainly can happen. And it's due to the rapid shifts in hormones, decreased sleep, stress as well. And like I said, migraine might improve during lactation. And when we talk about medications and safety in pregnancy, there's kind of a cutoff that was used that Ross came up with in 2014, that if the medication crosses over to milk in 10% or less than the maternal dosing, then it is considered a safer medication in pregnancy. And so that was particularly set up as the therapeutic monoclonal antibodies study, but really it also is for any medication that's kind of the cutoff is you want the medication to cross over into the milk less than 10% of the maternal dose. Next slide. So on liquid gold, human milk is precious, and for those with supply issues, it's hard to make, and it is indeed okay to cry over spilled milk. I had tenuous supply, and with my firstborn had to do inclusive breastfeeding, and by that I mean I was able to breastfeed but needed to supplement some with formula. And to any of us who have had supply issues, gosh, is it so important that somebody doesn't utter the words pump and dump. And so for that reason, there's so many different options in terms of preventative and acute medication for migraine disease that there's really no need to pump and dump unless there's a select medication that happens to be on a list that is the medication that works for you, and then it's worth considering that. But the way I think of it typically is, unless there is and this is based on mom's wishes. If a mama wants to breastfeed, I'm going to do absolutely everything in my power to pick a medication for them that lets them fulfill their wishes. Next slide. All right, so I tried to squeeze all of this onto one slide on purpose, so that if you do want to screenshot it, that's perfectly fine. That's why it is in microfilm, so I apologize for that, but wanted to share it in really a concise way. So when we look at those preventatives, you'll see that a lot of the medications are on there. You can have your amitriptyline or your nortriptyline, your propranolol and timolol, your verapamil, gabapentin, magnesium, B2, SNRIs. So those are things like Effexor, Cymbalta, Pristiq. Now, ones that need to be used with a little bit more caution: atenolol, topiramate, butalbital, which we'll talk more about that shortly, and Flexeril. Flexeril has weak tricyclic qualities, and so the problem with the butalbital and the Flexeril is that they can make the baby drowsy. And so I will have somebody do kind of like a test dose, and if they take the medication and breastfeed their baby, and then their baby sleeps for longer than the normal amount. Let's say the baby's typically feeding every 2 hours, and they have their sleepy Flexeril milk and they sleep for 4 hours instead, then I would say, maybe that's not the best fit for us at this point. But that's sort of been my approach, is to have almost a test dose to see if it makes the baby sleepy. And sometimes it doesn't, and that baby continues to wake up and feed exactly how it should, and I don't have to worry about weight gain with the baby or anything, because it's not having increased somnolence because of the medication. Now, there are certain medications that are worth avoiding: Depakote, Nadolol, tizanidine, zonisamide, and also, although they're safe in terms of the milk itself that the baby would receive, it's that it can decrease milk supply, and that's the antihistamines, including Benadryl, diphenhydramine, which is oftentimes used in an acute headache combination or acute migraine combination therapy. Otherwise, I know that people will sometimes call it a migraine cocktail, which is a term I despise, because there's nothing fun about migraine, and so there's nothing cocktail-like about it. But that acute therapy it's sometimes used in. But the issue is I really, really don't want to cause tenuous supply for my patients. You'll see that there's L1s, L2s, L3s, et cetera, that are listed after that, and that is Hale's lactation categories. Thomas Hale out of Texas Tech University is the source for all things related to pharmacology in pregnancy and lactation. There's an app called Infant Risk that is run by Thomas Hale's group. There's I think the layperson's version of Infant Risk, which is technically more for healthcare professionals, was the lay version is Mommy Meds. All of these are very helpful. And then there's the desktop version book, which is called Mother's Milk and Meds. So lots of different ways that Thomas Hale has gotten this information out, but it is one of our main resources that we turn to. Next slide. All right, and then Botox is a preventative in lactation. So everything we've been talking about so far are preventatives. And just to recap, American Headache Society recommends that somebody should consider a preventative if they're getting 4 or more migraine days per month. And so if somebody's getting 15 or more migraine days per month, or 15 or more headache days per month, of which 8 have migraine features, that is the definition, the International Classification of Headache Disorders definition of chronic migraine. So they don't have to have 15 migraine days per month. They have to have 15 headache days per month, of which 8 are migrainous. And so it is listed as a Hale's L3, and it's extremely unlikely to cross over into the plasma or milk compartment. It's a large molecule, and it would have a difficult time entering the milk compartment for that reason. There are definitely differing opinions. I do Botox for my chronic migraine patients during pregnancy and during lactation. Some other providers do not feel comfortable doing that, and so you are definitely going to find a mixed bag with that. You'll probably be more likely to find somebody who is comfortable with that if they are obstetric neurology trained, headache fellowship trained, but even with that, it's a mixed bag. Next slide. And then CGRP antibodies in lactation. So these are things like arenimab, fremanezumab, galcanezumab, eptinezumab. And these are preventative for migraine in adults. And so the infants absorb antibodies from their breast milk in the first 6 weeks and onward, continue throughout the entire time that they feed, but to a slightly lesser degree. And this is where they get passive immunity. The postpartum length of IgA, but not IgG in milk, affects the levels of those. Both antibodies are highly variable from one person to another. The IgA is 26-fold higher than the levels of IgG. And these medications are all IgG based. It is poorly orally absorbed, and so for this reason, they have to be injectable medication. And so that is somewhat favorable when we're thinking about, even if some does cross over into the milk, if it's not very well orally absorbed, it bodes more favorably that it would not be absorbed well into an infant orally. So some people will use this with, after the first 3 months or so, even in a lactating patient. Again, nothing is FDA approved, and so discussing this with your provider is key. I definitely have had this discussion with patients, and I will sometimes use the CGRP monoclonal antibodies in a lactating mother after the 3-month mark because they are, and I have a typo in there, but so regardless, I will use it after the 3-month mark. Next slide. Now we're going to switch gears a little bit. So before, everything that we've talked about has been the preventative medications. Now we're talking about medications in lactation for acute treatment. And so acetaminophen, ibuprofen, Reglan, magnesium, caffeine, prednisone, elatriptan are all acute medications that can be used. So this doesn't mean that you have to give up your triptans. The AAP rated elatriptan is safe, and there's low oral bioavailability in the milk concentrations. Sumatriptan was looked at as well. Zomig is the only one that might be worth avoiding, just because there's, if somebody can use one of the other triptans that appears to have less of a bioavailability and less of a CNS penetration, it might be worth doing that. And then the other concern is nipple vasospasm. So there's really not a need for pump and dump with any of these. But next slide, please, and we'll talk about nipple vasospasm. So these are blanched, painful nipples. It's almost like a Raynaud's sort of disease, if you've ever heard people talk about Raynaud's. And so warm compresses, gentle massage can help. And it's because all of the triptans, they cause a 30% vasoconstriction. So it squeezes all of the arteries and veins by about 30%. And so I personally would avoid any kind of letdown, whether it's pumping or direct feeding, about 30 months after taking a triptan. Anybody who's had a triptan knows that about that 30-minute mark, there's that whoosh that happens where you can get kind of that hot feeling in your face and maybe some jaw tightness, heaviness across your shoulders. These are all the things that I experience when I take triptans. And so around that same time, that's really when you're hitting that peak plasma concentration. And so your issues with things like nipple vasospasm are also going to be a lot higher at that point. So if you're able to nurse or pump, take your medication, let that whoosh, let that feeling kick in, and by a couple of hours later, if you need to, express milk in one form or another, that's fine. And again, it's not that the milk is bad, so there's no pumping and dumping. It's just more that your nipples might thank you if you are able to avoid letdown during that really kind of strong period of time. Calcium channel blockers can be helpful if somebody has pretty severe nipple vasospasm. And it's worth noting that people can have nipple vasospasm even with nothing to do with taking a triptan. So if this is just something that you have experienced without even having one, it's worth talking to your OB or your lactation specialist about it, because there are things that can be done, again, like warm compresses, gentle massage with medications as well. Verapamil carries somewhat limited evidence as a headache preventative, but it can be used in this setting as something that helps block the nipple vasospasm. Nifedipine helps as well. However, nifedipine worsens headaches in a lot of patients, so I'm less inclined to go towards that one. And then, using other acute therapy if needed is certainly worth considering if triptan is just not the answer. Next slide, please. Marina, you are right. Not a huge fan of Butalbital. So there are some risks for congenital heart defects, including tetralogy of Fallot and pulmonary valve stenosis, aortic ASD. And so the risks have been reported around the time of conception. So it's best if we can avoid it. Our OBs across the entire nation hand it out like candy, and I'm not quite sure why it's been drilled into them that it's somehow okay, but I disagree with them. An American Headache Society and American Academy of Neurology put out a position statement in 2013 called Choosing Wisely that stated that butalbital containing and opiate containing products should be avoided essentially at all costs and should be used as a last resort in patients with recurrent headache disorders, as it increased the rate of medication overuse if they're used anything more than about 5 days per month. And that can then cause the headaches to occur more than 15 days per month. So medication overuse headache Marina described it great, how that itself is headache. It doesn't have to have migraine features, but so it's that happening in addition to migraine. And so there's this perpetuating problem where one is getting medication to reduce headache in addition to their migraine disease. So avoiding it would be my strong recommendation. Next slide, please. All right, so this is another one of those fun kind of hot topics. I think I'm talking about all of the things that are controversial, like Botox and monoclonal antibodies and Gepants and lactation, which is why I always give that caveat that nothing is approved, because you will find some people who get nervous when talking about all of these in pregnancy or in lactation. So Gepants in lactation, the ubrogepant, atogepant, rimegepant are, well, ubrogepant is acute, atogepant is preventative, rimegepant is acute and preventative. And so lumping them together sort of makes sense because they're used for one or the other. And they are CGRP antagonists, and they're orally administered as opposed to our monthly migraine shots. And so these reach a milk level of less than 0.5%. They are high protein binding, and they're a rather large molecule. And so they're really just not crossing over into the breast milk. And so this is kind of hot off the presses, that the medication is really not quite making it into the milk. I feel comfortable using Gepants in lactation. And again, you will find others who do not, but trying to find a headache neurologist who will work with you, I think is key. And that's where it can also be very empowering to share this information with them if they have some level of hesitation. Next slide, please. So this is one of my favorite nursing pictures, and Marina, too many things in common in terms of us both struggling with migraine disease, having a 6 and a 7-year-old, and the fact that we ended both of ours with superhero pictures, and we did not plan that. This is just naturally what we both picked. But this is just Wonder Woman feeding Superman. You can see Superman in my arms right there. And it's sort of ironic that I picked this picture because I struggled as well with not feeling like enough. I think that it's a major problem with a lot of us where, between balancing being a new mom and some tenuous supply, struggling with migraine, working full time as a resident at the time when I had my firstborn, it's hard. All of this is hard. And so I agree completely with Marina that having your support system, having others that you can turn to, and in my case, even if I was faking it until I made it and making myself dress up like Wonder Woman, so I could feel like the badass mom that I wanted to be, then so be it. But I think that each of you are really amazing, and just know that you are enough, and you are Wonder Women as well. You are balancing having migraine disease with having your wonderful families. Some of you work at home, and all of that is hard work as well. And so all of us are just doing the best we can, and so keep it up.